Hello ladies and gentlemen, I am Dr. Aurangzeb, and in today's presentation we are going to discuss the cardiovascular implications of COVID-19 infection. We know that underlying cardiovascular diseases is associated with more severe manifestations of COVID-19 and higher mortality rates. There can be primary cardiac involvement such as arrhythmias, myocardial infarction, myocarditis, and secondary cardiac involvement in the form of myocardial injury, raised cardiac biomarkers, and heart failure. The objectives of today's presentation will be to discuss the presentation and management of patients presenting with severe cardiac complications of COVID-19 infection, the heart-lung team approach, and acute mechanical circulatory support in patients with cardiovascular collapse. A brief overview about COVID-19 and the cardiovascular diseases. We know that cardiovascular diseases is one of the most common comorbid conditions in patients with symptomatic COVID-19 infection. And by cardiovascular diseases, we mean stable and unstable ischemic heart diseases, acute coronary syndrome, heart failure, and cerebrovascular diseases, and peripheral arterial diseases. The majority of patients are having hypertension. This group of patients comprise about 35 to 57%. Coronary artery disease is present in about 10 to 17% of the patients, and heart failure in 6 to 7% of the patients. In 30 to 35% of the patients who die of COVID-19, they have underlying cardiovascular diseases. And the case fatality rate among patients with cardiovascular disease can be as high as 10.9% compared to 0.9% in patients with no comorbidities. Few words about the mechanisms by which COVID-19 infects the host. The SARS coronavirus 2 invades the cell by binding with the ACE2 receptors. One of the implications of this mechanism is that by increasing the level of circulating angiotensin II, there is urinary loss of potassium, which could contribute to arrhythmias. Now coming to our main topic, the primary cardiac involvement in patients with symptomatic coronary artery COVID-19 infection. Arrhythmias. So arrhythmias can be primary. These include ventricular tachycardias and ventricular fibrillations. These are the late manifestations of COVID-19. More common in patients with myocardial injury. The primary cardiac arrhythmias are more common in patients with myocardial injury. And these arrhythmias may point to an underlying myocardial inflammatory process. Some patients with may even develop out of hospital cardiac arrest, and most of the in-hospital arrests are non-shockable rhythms, asystole in 89% and pulseless electrical activity in 4.5% of the patients. We already discussed that hypokalemia may also contribute to the development of arrhythmias in these patients. Secondary arrhythmias may be due to drugs such as hydroxychloroquine, which could lead to long QTs, thereby precipitating arrhythmias. And combination of hydroxychloroquine and azithromycin is associated with more profound QTc prolongation and adverse events. Therefore, baseline corrected QT of greater than 450 millisecond is implicated with more QT prolongation, and therefore baseline and follow-up ECG should be recorded in all such patients. If hydroxychloroquine has to be administered, although recent studies have uh, defied any potential benefit of this medicine, but it can be used in some patients. So in that scenario, monitoring and clinical assessment of renal functions, electrolytes, and congenital long QTs or other QT prolonging medications should be done. Bradycardia should be sought as a warning system, as episodes of torsade de pointes are precipitated by bradycardia. How are we going to treat these arrhythmias? The first thing is that you should treat the reversible causes, and treatment of arrhythmias should be according to the guidelines, whether it's a tachyarrhythmia, a bradyarrhythmia, a ventricular tachycardia, a VF, or requires drug therapy or device therapy. It should be in line with the current practicing guidelines. Could be in the form of antiarrhythmic medications, or it can be transvenous pacemaker insertion. And for refractory arrhythmias, mechanical circulatory support should be considered. The second important primary cardiac complication in these patients is acute coronary syndrome. Okay, COVID-19 poses many challenges in the treatment of patients presenting with acute coronary syndromes. These include diagnostic uncertainty, rapid COVID-19 testing, PPE-related issues, risk posed by diseases to the healthcare workers, ACS incidence increases in the presence of viral infection. We know that inflammatory state which leads to plaque destabilization in such conditions, and a higher threshold for the cardiac cath lab activation should be kept. STEMI should be treated preferably with primary PCI with fibrinolysis reserved in other cases with extreme caution. Non-STEMI patients should be treated on a case-by-case basis. The third important primary cardiac complication is myocarditis. Data from the endomyocardial biopsies and CMR has demonstrated that myocarditis could be a cause of the myocardial injury. Infection control is one of the main limitations in utilizing these modalities on a larger scale. Therefore, if suspicion is high, integrate the following to make the diagnosis. Use your clinical laboratory ECG, echo data to guide you which patients could be subjected to these tests in order to make a diagnosis of myocarditis. Management of such patient is also tricky because limited data is available on the management. Some investigational therapies are there which include antiviral drugs, remdesivir, lopinavir, and ribavirin. Anti-inflammatory drugs in the form of anakinra, intravenous immunoglobulins, and some even advocate statins. Early use of immunoglobulins and anti-inflammatory therapy is most important aspect of management. Even corticosteroids can be employed in such patients. Coming to secondary cardiac involvement. Acute myocardial injury by definition has a multifactorial mechanism. It could be because of myocarditis, it could be because of myocardial infarction, could be because of microangiopathic cytokine storm or arrhythmias. Some even attribute the direct myocardial injury mechanisms, for example, acute plaque rupture, direct invasion of the cells by the virus, and endothelitis. Indirect myocardial injury in the form of cytokine storm, in the form of as a part of microangiopathic process, or could be due to the type 2 MI. Heart failure is a not uncommon complication, and raised circulating BNP or cardiac troponins should raise the suspicion of congestive heart failure. Limited transthoracic echo or point-of-care cardiac ultrasound can be done if the diagnosis is uncertain. Other cardiovascular complications include venous and arterial thromboembolism, major arterial emboli like CVA or systemic thrombosis has a multifactorial etiology. Elevated levels of D-dimers and circulating FDPs are associated with increased mortality. Pulmonary embolism, which is the most dreaded complication and a most common event. It contributes to cardiac injury detected by levels of troponin elevation, and also contributes to the vicious circle in patients with acute respiratory distress syndrome. If cor pulmonale develops, it can be a cause of sudden cardiac arrest in these patients as well. How to manage these patients? Any patient with COVID-19 infection and has presented with thromboembolism, venous and arterial, or those patients who are at risk of developing such complications, venous and arterial thromboembolism prophylaxis should be the cornerstone of managing such patients. Low threshold for therapeutic anticoagulation if clinical evidence of thromboembolism is there. We have the options of low molecular weight heparin in the absence of renal impairment. We know that if there is renal impairment, particularly if the eGFR is less than 30 ml per minute, then low molecular weight heparin carries a risk of bleeding. Systemic fibrinolysis in patients with massive PE, and particularly by massive PE we mean those patients who have hemodynamic compromise, and other treatment options remain a matter of debate, as well as the use of prolonged anticoagulation in those who survive. Acute circulatory failure. Okay, so shock and multisystem organ failure is a hallmark of COVID-19 infection, particularly the fatal events in patients. This is one of the dreaded complications that you should be vigilant to be aware of. Uh, it can be a distributive and septic shock. Both these entities predominate, but mixed shock is also reported. Corticosteroid, then the circulatory support in patients with underlying congestive heart failure, and it should be treated by multidisciplinary team. Patients almost always develop bilateral pulmonary infiltrates, which can progress to acute hypoxic respiratory failure. Pulmonary artery catheterization is very helpful in this regard. Clinical and lab parameters for shock include the renal function tests, liver function tests, serum lactic acid. You should be monitoring the urinary output of such patients. Okay. What is the role of ECMO in such patients? That is extracorporeal membrane oxygenation. It can be employed in patients with refractory hypoxemia. We know venous ECMO is FDA approved. We know arterial ECMO may also be used when there is refractory cardiogenic shock or mixed shock. Other thing which can be the other modality and the treatment option which can be employed in patients with circulatory failure and collapse are inotropes, cardiogenic shock or mixed shock, but beware of arrhythmias. Intra-aortic balloon pump can also be employed, and percutaneous left ventricular assist devices. Primary PCI, particularly if cardiogenic shock is because of acute ST elevation myocardial infarction. Chronic congestive heart failure, this is another thing that we may encounter. It is a frequent comorbidity present in patients with symptomatic COVID-19 infection, and if COVID infected, they should be closely monitored for decompensation. The precipitating factors might include IV fluids, systemic inflammatory response, drug-induced cardiac toxicity, renal failure, and judicious use of volume expanders and avoidance of NSAIDs can be used to prevent the acute decompensation in such patients. So we know that IV fluids and systemic inflammatory response and drugs and even renal failure can precipitate heart failure in these patients who have a chronic stable course. So if such patients who have chronic congestive heart failure and they become infected with COVID-19, in such cases, judicious use of volume expanders and avoidance of NSAIDs may be one of the mechanisms or approaches by means of which we can prevent the development of acute heart failure in these patients. A few words about COVID-19 and ACE inhibitors and ARBs. It's a matter of intense debate as the virus used the ACE2 receptors to infect the host cells. Could they potentially increase infectivity and mortality? This is a major question, and it has not been proven to date. Retrospective studies have shown lower mortality with these medications compared to unknown users. These medications should not be discontinued in COVID-19 patients already taking them. Should be avoided in patients with acute kidney injury, in patients with pro-inflammatory manifestations, and obviously in patients who are in shock. So it means that patients who already are taking these medications for one or the other purposes, for hypertension, for heart failure, these should be continued if they don't have any acute renal issues, pro-inflammatory manifestations, or obviously hemodynamic collapse. So how COVID-19 is redefining our priorities in cardiovascular care. Healthcare professionals are under immense stress while treating patients with COVID-19, and we know that recommendations to inform clinical decision making must include telemedicines for triage of non-emergent patients and prescription renewals, defer all non-essential diagnostic testing, continue to treat emergencies and perform diagnostic tests on a case-by-case scenario after discussion, reschedule routine elective cardiac surgeries, and because of the reason mentioned, even non-infected individuals also suffer from the restrictions imposed by the pandemic. Because in many centers elective procedures are now rescheduled, and so the even non-infected patients have problems in managing their disease states. So the final slide, we will just briefly look at what should we clearly get from what we have just revised. So COVID-19 can have multiple impacts on cardiovascular system. For acute cardiovascular complications, use a multidisciplinary team, and that should be the norm. In suspected cardiogenic or mixed shock, further assessment should be done to better manage the patients. Several important questions needed to be answered. And COVID-19 have an indirect impact on the delivery of cardiovascular care by reducing the efficiency of the existing pathways and reduced use of health services by the patient.